joining us and discussing your recent article with us. I'd like to start off by giving the audience a brief introduction. Dr. Andre Kumar is a clinical associate professor at Stanford University School of Medicine, where his work focuses on point-of-care ultrasound, medical education, and the use of technology to expand access to high-quality diagnostic imaging. He has led multiple studies examining how clinicians acquire ultrasound skills and how AI-based tools can support both learning and real-world clinical workflows. Dr. Kumar is the lead author of the randomized controlled trial we'll be discussing today, which evaluates whether deep learning guidance can help novice clinicians acquire multi-view echocardiograms more efficiently and with higher image quality. This research that speaks directly to some of the most important challenges facing cardiac imaging today. Welcome, Dr. Kumar.
Thank you so much for having me. Really excited to talk with you about AI-guided ultrasound training and the study that we did. Before we begin, I just want to mention that this was an investigator-initiated study, and UltraSight, the company involved in the study, did not influence the design, analysis, or the publication, and I do not have a financial relationship with UltraSight, and the views I'm expressing are my own. So let's get into what we were looking at with this study, our goals, and what we found. Okay. There is a critical shortage of sonographers globally. If you look at countries of low middle income status, there are approximately 1 million patients per machine. And if you examine the United States, ultrasound demand has increased about 55% over the last decade, but we've only trained about 23% more sonographers over this period of time. So you're seeing a widening gap in the demand and what we're actually putting through in a pipeline. And this is a huge barrier for timely diagnostic imaging worldwide. And point-of-care ultrasound can help address these shortages in a variety of clinical settings because it's diagnostically expedient. It can be provided in areas where you traditionally are having difficulty bringing in a large cart-based machine. But there are a lot of bottlenecks in POCUS adoption. What are these key bottlenecks that are preventing POCUS from being utilized more widely? One of the key questions we think about that often come out in surveys is device access. We just simply don't have enough devices. Well, we've done 2 randomized studies in the past that I'm showing here, where we gave trainees access to their own personal ultrasound device compared to trainees who just had to use, the cart-based machine that's shared throughout the entire hospital, like the ICU and all the different units. And what we found was there actually wasn't meaningfully significant improvement in skills, either interpretation or how they were to acquire these images. So I think device access, although commonly cited, is actually not the issue. I think the bigger issue that we have is training and mentorship. Traditional ultrasound, depending on what type of scan you're doing, it's going to take you maybe 20 to 30 supervised scans. And the biggest barrier we have right now is the training faculty. Faculty mentorship are these limited resources, particularly in areas that do not have traditional training pathways in POCUS. And if you're really interested in bringing that into your practice in some of these settings, you really may not have anyone to turn to. And this is where I think AI can be an interesting tool to potentially scale the use of POCUS. And the real question we have to ask ourselves is, can real-time AI guidance really impress this learning curve? So here's how I think AI can help in POCUS. It can be thought of as a real-time acquisition coach rather than something that is, post hoc as an interpreter. And it provides you continuous feedback during the scanning process. And it helps learners shift from the cognitive load of, oh my gosh, what am I seeing? There's so many different objects here to, okay, what do I need to do to optimize this image better? And this allows for scalability across different centers, different health settings. Mentorship has traditionally been a barrier. And this is something we were really interested in showing previously. This was a study we did, a randomized study published in Chest Pulmonary, looking at AI guidance for a single view, looking at apical 4-chamber. And we randomized participants to have this AI tool versus just their own personal device. And we brought them in to the lab about 2 weeks after giving this device to use for their own practice. And we found that they were faster when they had the AI guidance. They were about 33% faster on the follow-up. Now, the big thing about this was only a single view, and a single view, although extremely important, may not be generally applicable to all different types of cardiac scans when you're thinking about, for instance, a limited transthoracic echo. And that was really the impetus for the study question for this particular paper that we're talking about today, which is, does real-time AI guidance improve the speed, the image quality, and successful image capture for a limited echo among POCUS novices? How did we approach this? We conducted a randomized controlled trial. We had 38 internal medicine residents, no prior training, and we randomized them. We randomized them 1-to-1 to have either the UltraSight enabled device versus a standard device, which was the Lumify without any AI capability. And we gave them these devices. They could use them for 2 weeks on their own, on a hospital ward, however they see fit, for their own self-directed learning, patient care. We didn't provide any feedback on their scanning. They were really just on their own. And then after doing a baseline assessment at the time of randomization, we brought them back 2 weeks later, and we wanted to see how they did. And just a couple of things about the randomization in our workflow of the study. As I mentioned, they were randomized 1-to-1 to either receive UltraSight or non-UltraSight capable devices, but both times they were using Lumify. They had access to identical hardware, educational resources. No feedback was provided, and we did these assessments. Now, importantly, we did these assessments on a different type of probe, which was the butterfly probe, and we did that because we wanted to assess, was there truly a gain of skill rather than familiarity with the device? We had several interested in. We looked at the time to acquire cardiac views. We felt that was the most important one because time often means quick diagnostic assessments, and that's what we really wanted to focus on. We also wanted to examine image quality. We used a simplified scoring method called the rapid assessment for competency in echo, also known as the RACE, to grade essentially the quality of these images. We also wanted to look at how often they were able to acquire these images, what are called failure rates, and what did the users think of the experience. A little bit about the UltraSight device and system that we used for this. It's essentially a neural network that provides real-time guidance. When you place the transducer on the patient, it provides directions to the user on how to obtain an optimal image. It does it for the 5 classic cardiac views of the parasternal, long, short, apical 4-chamber, subcostal, and IBC. And it overlays on the existing hardware that you're using, the existing probe. So in this case, the Lumify. And it's been basically a very large model trained on over 50,000 transthoracic echoes and has FDA approval, really nice accuracy and correlation with expert ratings. Here are our groups, and one of the most notable things we just want to mention is the high retention we had at 2-week follow-up. Both groups were able to come in 2 weeks later to the lab to do the testing. We had a really nice distribution of training levels of POCUS novices all the way from first year to third year residents. Pretty minimal exposure to POCUS in these groups, 21% in the UltraSight group and 11 in the control. And I think the most notable thing is we were able to track how often they were using these devices with an electronic tracker, and we found that there were substantially no differences in the amount of times they were using these probes for patients, on average about 5 times over the 2-week period. For our main outcome, this is what we found. There was a dramatic reduction in the total amount of time to obtain a limited echo, about 43% faster in the UltraSight group versus the control group. And we're about a substantial difference of over 100 seconds, which can make a substantial diagnostic delivery capability for this AI ultrasound. And this was statistically significant and had a very large effect size as well. When we looked at specific views, we found that there were a couple of specific views that were really driving this overall improvement. The parasternal long, parasternal short, and apical 4-chamber, which are traditionally some of the more challenging views to obtain. And we found that in the UltraSight group, they were much faster at obtaining them. How did they do on image quality? This was an important thing. It's one thing if you're scanning fast, but you also want to make sure that you're acquiring really good quality images. And here we also found that the UltraSight group on follow-up had higher image quality scores, this race score, compared to the control group. Just a quick thing about how we assessed it. We had three experts review all of the images acquired. They were blinded to who these groups were, had no idea who was ultrasight, who was control, and they rated it on the race scale. And we had pretty good inter-rater reliability, greater than 0.87. And also, as I mentioned, in addition to statistical significance, this was a very large effect size we were seeing. So they're faster and they're obtaining better image qualities. This was mainly driven for the image quality by the parasternal short and the apical four-chamber, and we didn't see much of a difference for the other views. And just as I mentioned, the baseline was pretty similar between the two groups. This was also another fascinating finding. I think one of the most underrated findings of the study, which was we dramatically improved the image capture rate over by 94% in the ultrasight group. So when we took these people into the lab at baseline, we had them do a full transthoracic echo on a standardized patient, and we wanted to see how often they could get the views. And at baseline, ultrasight had statistically insignificant, but a good amount higher, 18 incomplete views. And then on follow-up, when we had 18 before, only one incomplete view was done in the group. And this was a dramatic reduction. And in fact, the control group increased their failures over this time period. How do people use this technology? We asked them at the end, how do you feel about AI and POCUS in general? And this was where it was interesting. Even though we could see a very clear benefit of what the system did in terms of their ability to acquire the images, the trust in the system wasn't quite there. If you ask a general trust of AI functionality in ultrasound, only about half of the people felt that they would trust it. Similarly, the UltraSight itself, which is providing some positioning guidance, only about 70% had trust for it. And additionally, if we were to add features such as interpretation, only about 70% would feel trustful of it. So you're seeing this really interesting phenomenon where people are actually perhaps getting more skilled with the AI, but the trust itself is not all the way there. Okay, so what are the implications of this study? I think there are several. If you look at the traditional training model and you're looking at the barriers for scaling and adoption, one of the big things that we've been talking about is just the number of scans you need to do, maybe 20 to 30 of directly supervised scans to obtain this basic, really challenging and a lot of resources. Compare that with what could occur with an AI-enhanced training platform where you need fewer scans, you can actually do independent learning, but you're still receiving this real-time feedback, and you're actually obtaining competency perhaps more quickly. Why do we think this could work? Well, I think when you're looking at AI systems, there's potential benefits, especially if you don't have a mentor with you. One is it's providing immediate corrective feedback. It's helping to reduce the trial and error frustration where you're just blindly scanning. You don't know what you're doing. You don't have anyone there to help guide you to obtain an image. It reinforces correct movements, which is extremely important. And it's just aligning with the principles of deliberate practice, which is focused, intense practice, which is sometimes not always fun, but is achievable and has a specific goal in mind. I think AI ultrasound fits many of those items. Additional educational and clinical implications is if you're thinking about AI integration into POCUS, it can help train, it can help scale it. It provides potentially safer task shifting and monitoring. I think more than anything is not going to replace teachers, but it can definitely offer a hybrid education model and definitely be complementary to what is existing. It also raises new competency questions. A lot of these studies on learning curves are based off of traditional in-person monitoring feedback. And what does it really take to be competent now in this AI era? There are some limitations that we definitely need to bring up as part of the study. It was single center, which is going to limit its generalizability to other settings. We used a standardized patient at the baseline and follow-up, and we all know when we're scanning with POCUS, we don't always have patients with really, really great, easy attainable windows. That's a very important limitation. We had a relatively short follow-up of 2 weeks, and this has important implications because we don't really know long-term how people will attain and maintain these skills that they've acquired with AI guidance. And then blind the participants. Although the reviewers were blinded, the participants knew which tool they were using, of course, and so that can introduce the Hawthorne effect, where they knew they were being studied with the AI device. What does this mean for diagnostic access? The implications of the study is, AI devices may improve acquisition speed and image quality for novices. It may, in turn, address really critical gaps in diagnostic imaging capacity by enabling non-specialists or novices to obtain these images. And we have a lot more work to do. Multi-center studies are needed to evaluate the performance across diverse patient populations and clinical settings. So, what are the key take homes of this study? It's, well, one, ultrasound guidance meaningfully improves both speed and quality of cardiac focus with these novices. I think this is not a replacement of clinician. This is an augmentation tool that can be used in the future, and we're really using it to accelerate human skills as part of it. So happy to talk a little bit more about.
Thank you, Dr. Kumar, for a great presentation, and kudos to you and your team for such impactful research for something that's transforming kind of our discipline of point of care ultrasound. I do feel like AI will reshape how we look at training and education in the near future. What I'd like to do next is kind of ask you a few questions. I think you've answered a lot of kind of where we think this research is going, but you mentioned two important takeaways from the research. One being AI using UltraSight for the study produced faster imaging, and it produced higher quality images going forward and a bigger miss rate. So if you think about it from a protocol, you're going to have better images across all spectrums of a multi-view echocardiogram. Can you describe what the current protocols at Stanford are and how a technology like this would help both you at Stanford, as well as what you think the rest of the country would benefit from it? As we all know, Stanford's very academic and the rest of the country has less resources per se as Stanford has.
Really great question. I would say that our workflows do match a lot of what you see nationally, where you have individuals who feel comfortable with POCUS, have received some training, are using it as part of patient care. There's no set governance that we have related to credentialing, so anyone who feels comfortable can scan. That may change in the future. But the workflow is you have these images, you save it to our PLAX, and then there's a review. There's potentially integration into the EHR, notes, billing, that a lot of health centers across the country, academic community, are really struggling with it and thinking about. But I also know that what our center does that's very similar nationally is you have individuals who maybe have taken a couple of POCUS courses, or it's been a little bit since they've done it in residency or fellowship, and they just want a little bit more practical guidance and mentorship. And for us, that involves going to your mentors to help review some scans for you or the quality assurance protocols. But that also is something that is delayed. You have to do your scan, make your decision, and then on the retrospect, you're able to receive some of that feedback. Where I think a tool like this is going to be extremely helpful is for that real-time acquisition feedback, where you can enable more users in your system to acquire these images to make real-time decisions and better integration of those decisions into the EHR. I think what's going to be fascinating for us to think about in the future is as you implement a lot of these AI tools in a health system, and more users are potentially scanning, and more users are obtaining potentially diagnostic images. What are the back end that really of does that increase the number of scans that are ordered, like formal echoes as a follow-up to a finding that's done on point of care ultrasound? Does that lead to more false positives, false negatives? These are, I think, really, really important questions with AI that need to be addressed. You see some of that discussion and research that's already been done for regular POCUS, where you're not really seeing, for instance, the ACP put out that really great article about point of care ultrasound in the emergency department, not really seeing a dramatic increase in false negatives and errors. But when there's AI, more users, more scanning, more novices, I think that is an interesting thing for us to think about. But overall, a generally positive thing that I think is going to come from this with AI and scanning and more users.
I totally agree, especially on the aspect of how AI in the setting of a workflow has to be validated, has to be done with the novice to kind of show, can we offload some of these either limited echoes that are being done by the echo lab or these comprehensive echoes that are being done, but really have one question in mind.
Yeah.
Can we do that at the bedside with the tools that we're being given now? But let me take it a little bit. We've started really broad, and let me just narrow it down a little bit. Based on your experience running this trial, where do you think a technology like AI guidance would be most beneficial in the hospital setting?
In the hospital setting, I think it's going to be most important at the point of triage and the first 24 hours of a patient's admission. I think that's where it's going to be most impactful. Patients being admitted to the hospital from the emergency department and having residents more readily obtain these ultrasounds and hospitalists more readily obtaining these images with AI guidance. And if particularly if you can factor in an interpretation component to it, not just acquisition, you're going to see a lot more data being available in hours of admission, which can have huge impacts on patient care. Secondarily, definitely patients who are already hospitalized and they're becoming sick, your rapid response, your peri-ICU, ICU population, where there can sometimes be a delay in getting an echo. It might take 2 or 3 days to get that formal echo, and you need to make decisions now on fluids or pressors or what your decision is on a patient's cardiac output. I think these are all really, really just nice ways to increase the frequency that POCUS is being used, because we all believe, the positive impact it can have on patient care, and any opportunity to increase the frequency that's being performed safely, I think is well worth it, and that's where it's going to be most impactful.
Amazing. You talk about the rapid response team. Now, if we think about busy emergency departments or ICU settings, with your results of reducing scan time and improving image quality, how do you think those factors will change clinician behavior and adoption of a technology like this at the bedside?
Great question. I think it all comes down to friction. You know, you're a busy clinician. I work in the hospital, busy, and we can think of so many things in our lives and our jobs where it just takes up time, or it's just somewhat of a pain to do, and because of that, we don't do it in the same extent that we could, even though we know it may be beneficial. It's just something that has a lot of friction for us. Tools like this that reduce that friction by making you have spend less time wandering on a patient's chest with a probe, and having a little bit better accuracy and more guidance on how to acquire the images, even if you are more experienced and you feel comfortable. Anything to improve that expediency, I think, will increase adoption. And that's in healthcare settings, where I think the real potential for this is going to be is outside of hospitals and cardiovascular screening. where you're having not doctors, not nurses, but medical or medically affiliated personnel acquiring these images, remotely uploading them for a health system to look at or a cardiologist to review to make management decisions. I think that's where it's going to be um, extremely impactful. And it may get to a point where AI progresses where you're seeing things where it's actually you're doing what are called blind sweeps, where you place the probe on the chest and a software is basically directing you how to move the probe and it tells you to hold the probe still that you've had a good image and it uploads it to the system. You're seeing things like that. Jeff Stringer put a really great study together looking at blind sweeps to estimate gestational age in Zambia and North Carolina. I wonder if we can do something similar for cardiovascular screening in patients and populations that are very high risk for these diseases.
I think you're referring to sweep technology. Am I correct in understanding that?
Yeah, yeah, sweep
Where it
technology.
takes the whole image, you just run it like a lawnmower technique across the chest, and you get out the output is everything you've ever dreamed of. Um,
Yeah, that's exactly it. Just doing doing a true lawnmower pattern where you're not even seeing what the images are. It's just basically a software that's guiding you. But ultimately, it acquires images that are suitable for an AI algorithm to interpret it on its own, or create a report, or generate images that could be uploaded to a health system, a cardiologist to look at further. I think that's the goal. That's the future vision for expanding POCUS access. I still think very much, though, that there will definitely be a need for these kind of technologies for clinicians such as myself at the point of care, and anything that's going to reduce that friction will be extremely helpful.
yeah, and also think that it really comes down to the quality of the image obtained to activate that diagnostic output that you're eventually looking for, whether that's fetal heart rates when you're talking about the sweep technology in OB, or in general when you're sweeping across the chest, or having our high quality images like you have demonstrated here to evaluate for EF, aortic stenosis. It really comes down to the as good of an image coming in is how good of an output you're going to get. And I think that's where this is going personally as well. To just get a little bit more narrow, you talk about the largest gains being associated with the PLAX and four-chamber review. Why do you think AI guidance was so helpful there in particular?
I think those are personally, I think those are some of the more challenging images to obtain in general because of, patient habitus. Those are the ones we usually have to turn our patients for. We have to play around with breath technique. And if you're a novice, I think those are the particular views that are more challenging to obtain. So if you have real-time guidance to direct you in those particular challenging views, I think that's where you're seeing the most benefit. And it's also interesting because they particularly for the apical four chambers, they were fast, similar to what we saw previously with the different software, but then they also obtain better quality images as well. So I really think this real-time guidance is helpful for these more challenging views. And then let's not forget that we also saw a much lower failure rate with that UltraSight group. Again, pointing towards the fact that these are just sometimes very difficult views to obtain if you're a novice.
Completely agree. Thinking forward, if you were designing the next study, what downstream clinical or operational outcomes would you want to measure beyond image quality and acquisition?
So I'm imagining, okay, I'm putting a system like UltraSight in my health system, and I've already demonstrated to my hospital committee, hey, look, they're going to obtain these images more quickly. They're going to obtain, I think, diagnostic quality images, but better than a control sort of group or what's existing. So we already know that. Next, I think it's going to come down to utilization. If you have users in your system who are frequently adopting UltraSight or tools like UltraSight in their system and they're performing scans more frequently, what are the downstream implications on the health system? Do they order more echoes, fewer echoes? Are there potentially misdiagnoses? What does this do on potential length of stay, patient-related factors, ICU escalation? These clinical questions, I think, are extremely important. And when you look at the AI and POCUS field, a lot of really great researchers out there are looking at what we did here. Very similar studies showing that their algorithm is very accurate. It improves some sort of scanning data point that you want to acquire. What we really don't know as well is what does this do for patients? What does this do for the system, the costs related to it? And you can think about this in various different contexts. You could do this, you can think of a very focused patient population, say heart failure or syncope, losing consciousness. One of these patient populations where you think echo could be extremely impactful and is often overutilized. So that's one area. You could also think of using this in patients who are recently discharged from the hospital or had a recent MI and they need just follow-up imaging, and it's going to take them 4 to 6 months to get an echo, unfortunately, because of their health system that they're in, and they're not that mobile. Can you do a study that where you're using a tool like UltraSight where home health nurse or some medical staff is scanning, it's uploading it to a cardiologist, and they're making medical decisions based off of these point of care images in a very important patient population that would otherwise not have access. And what is that? What are those outcomes for those patients? What are the outcomes on the health system? I think there's just so much in this field that you can do that is really just we're of it. This is the time to be exploring it because we have demonstrated this value of this technology. We know what it can do. Let's turn it onto our patients now and see what is the impact it has on them.
I completely agree. I want to, all these outcome measures that you are addressing, I think speak to what an administrator would want to see to adopt this technology, whether that's in the hospital or their system-wide system. But let's think about this. Imagine yourself, you're in charge of the public health of the country, and specifically your niche is cardiac. What barriers do you think still need to be addressed to change the kind of ecosystem in health systems to adopt AI? And I say this because AI is still having a hard time being implemented in the healthcare system. So I'm curious your thought process through this.
Yeah, that's a great question. I think there's just like one fundamental that we have to think about with AI adoption in health systems and the barrier for that you were mentioning, and that relates to information security and having IT groups being very comfortable with these AI platforms being used on patients. Not to say that you're not observing right now AI integration into health systems. For instance, at Stanford, we have ambient scribe technology where it can listen in and create a note. And we actually have a chatbot now enabled in our EHR that we can ask questions to. So it's not like you're seeing no AI integration. But I think one of the fundamental things that we're seeing with this technology, with POCUS and AI, is a lot of it is cloud-based, where you're acquiring images for a patient and it's running up to a cloud of another of a company or whoever creates the software. The cloud is running its own algorithm and then it's spitting back at you the potential interpretation, especially interpretation standpoint. And to improve adoption, what I've been going through this for the last couple of years, that I think the biggest thing is you're just going to have products that provide this service on edge, meaning there's no cloud no internet access that you need to do. And I think that's fundamental because it's not just for the Stanfords of the world, it's actually for many of the medical camps, the refugee camps, the underserved areas where there is no access to internet. I was reading a statistic the other day about basically 40% of the people in the world do not have access to internet. So if we're thinking about where we can implement this, where it can be very impactful, we have to consider that. Specifically, though, in the US, the health system here, making sure that any solution that we have can integrate extremely well with what we know the concerns, justifiably so, that IT will have about privacy and ownership of patient data and where the flow of that data in a clinical care environment.
I completely agree. The component you mentioned about being on edge, I think is an overlooked concept to those that are not familiar with AI. The ability to not have to send to, even if the cloud is internal, but usually it's an external cloud with a computing model that produces the endpoint. Having it on device makes it much more simple, much more accessible, and to your point, makes it so those that don't have internet access, which 40% makes, a lot of sense in a lot of areas of the world, allows this technology to function there. I think you're right. I think that is probably the largest barrier between AI in general, and especially AI guidance and AI diagnostics in terms of echocardiogram and cardiac disease becoming routine in our healthcare systems. Now, I think the additional part here is that the research needs to validate what the output is so that when you think about comparing it to the gold standard, we're able to validate that those results are what every clinician is already used to.
Mm.
Now, in terms of your next research, what would you propose? What do you want to do next?
Yeah, great. I just to echo on your point right now, making sure that IT is comfortable with the endpoint is the biggest barrier for many clinicians, and it's also a big barrier right now for my research and what I want to do next. But where I'm viewing this, where I would really like to take this in the future is looking at these outcomes, having randomized trials where providers are utilizing these tools for acquisition or interpretation and assessing the utilization of it, demonstrating potentially to a health system you can save them X amount of dollars, hundreds of thousands, millions of dollars each year by reducing unnecessary echocardiograms. Like you were saying, a lot of patients, they get full echoes, even though it's, one specific question that can be answered with a limited echo. It's just the person putting in the order puts it in. Um, could AI technology such as UltraSight be beneficial in reducing the costs on health systems? I think that's where I want to go for my next study because AI, it's very important right now. Everyone's obviously talking about it. We're thinking about how we're going to integrate it with it. We really need to demonstrate its value, not just for patients, but for health systems. And when you see more adoption of health systems, it's usually going to relate to the bottom line of the financial incentive to do that. You demonstrate a financial incentive and patient care, you're going to see a massive adoption. We just haven't really had much research on that yet.
You're speaking my language, which is there's twofold studies, and both are critical to adoption. And I think this goes back to when you describe barriers. It's not just the IT, it's the research mixed with the economical data proving the return on investment for the hospital administrators to get buy-in from the collective all stakeholders within the system. I think the person that is able to solve those will advance technology and how we utilize it in our everyday life. Um, Amazing. Well, I do want to thank you for your time, Dr. Andre Kumar. Your work is incredibly impactful. It's going to change how we address our next vision here at UltraSight. And we are looking forward to your next proposals. We're looking forward to partnering with you, and we are excited for the future. Thank you so much for your time.
Thank you so much. It's been a real pleasure to talk about this, all things POCUS, AI, and really looking forward to our next collaboration.